Time to join us on this webinar today. We're glad that you'd engage with us around the topic that we have set aside for our time here. Our commitment to you is to take a topic that's oftentimes considered a right-brained, ethereal topic and make it very much a tactical, left-brained conversation. There's not a hospital in America today that is unconcerned about the patient experience. The realities of reimbursement rates and HCAHPS are weighing heavily on virtually every clinical and administrative team that we've interacted with on both the outpatient and the inpatient side of the house. So the case for change tends to be pretty clear. We're not going to spend any time on that today. You're likely listening to this webinar because you either play a role in the delivery of those scores, or you need for those scores to be moving in a positive direction, and you ultimately feel accountable for that to happen. Over the next 45 minutes, we're going to introduce to you a framework that has effectively moved HCAHPS, CGCAHPS, HHCAHPS, fill in the blank, as well as other leading indicators like employee and physician engagement, in many cases in dramatic fashion. The beginning place for our conversations right here, strategy versus culture. Now, if you ask a group of healthcare leaders, which we have done over and over again, which of these two levers are you spending more time on today? The answer is overwhelmingly on the side of strategy. Healthcare leaders say, well, we're trying to move our patient experience scores, and we do default to strategic levers to move the needle. When you follow that question up with, okay, so between strategy and culture, which today is having a greater impact on your patient experience? When you consider the verbatims on your surveys, on your HCAHPS scores, or whatever survey instrument you're using, what are you hearing? Is it culture or strategy? 96% of the healthcare professionals that we interact with or that we've asked that question to don't even hesitate. They say it's culture. So there's a bit of a paradox in this because intuitively, leaders know that culture matters. They know that it's having an impact on the patient experience. But the muscle memory takes them right back to strategy. So what we end up with is this highly imbalanced approach where most of the mind share and the strategic energy in the organization is dedicated to the new rounding tools, the new rounding questions, staffing levels, and our what tends to be ignored in that conversation is the underlying realities of culture. Culture is simply defined as the way that people think and act to get things done. And in many organizations, the culture just happens to evolve to become whatever it becomes unless we're intentionally and proactively managing it. So in the absence of intentionally and proactively managing it and not really being intentional about it, we end up spending more of our time on strategy. Now, the interesting thing about this, and there's a pattern that will sound familiar to many of you who have joined us here today, is because we're so focused on strategy, we tend to send spies out into the healthcare world. We send people to Mayo and we study what they're doing, or to Cleveland and study what they're doing, and we come back learning what they've done. And we come back, if I were to ask you, do we come back with having studied their strategy or culture? We know that we come back with what they're doing strategically. We implement that into our rounding philosophy or our patient experience work. And what we tend to find is the scores actually drop. And we're left going, well, so why is this happening? The top performers in our industry are doing this. Why isn't it working for us? And the reason for that is because really the secret sauce of the top performers is not, when you listen to what they're doing, while there certainly can be some brilliance in the strategy, the secret sauce really is the culture. And that's the piece that's very difficult to replicate. Another way to look at this is to think of culture as an operating system, or like an operating system on a computer. When the operating system functions, the apps run efficiently. When the operating system isn't functioning well, then you place those apps into the operating system, and the operating system actually rejects the app. Not only do they not embrace them, they just don't work. And that happens time and time again in a clinical environment. We learn something that we feel is evidence-based relative to the patient experience. We cut and paste that right into our operation, and we feel like our organization is rejecting the change because of initiative fatigue and the fact that you're throwing 50 new things at me that is supposed to fix the patient experience. People become numb to it and they just kind of shut it down. That's the pattern, and it's rare that we interact with a hospital system or an outpatient or in the outpatient world where these sentiments aren't very close to the surface, and sometimes they are leading to massive problems with clinician and administrative burnout. So where we're going to spend our time on this webinar is on two basic components of fixing or improving the patient experience. So when we talk about a patient-centered culture, there's consideration around the philosophy as well as the methodology, and we're going to start here with the philosophy. So what is the agreed upon philosophical approach to delivering on the patient experience? I'm going to take about 15 to 20 minutes to frame up that philosophy. And as I do so, the question that is likely going to be in your mind is, okay, so how do you do that? And know that we'll get to an overview of the methodology as well in just a few minutes. The model that I'm showing you here is the foundational framework that we use in our 30 years of working with healthcare organizations to help them understand how to not only manage but accelerate change. It's a very simple model that we refer to as the results pyramid. At the base of it, you have experiences. Experiences lead to beliefs. Beliefs inform actions, and actions produce results. So the model, just to give a really quick example of how the model works, let's say we hire a brand new charge nurse, and we send her through orientation, and on the back end of orientation, she is off and running. She's ready to, week 2, she's ready to go make it happen. And she interacts with Charles, another charge nurse, and she asks Charles if they can go to lunch, and Charles agrees, and they go to lunch. So while they're at lunch, the new charge nurse says, so Charles, I'm just getting my feet here. How do things really work around here? And Charles says, hey, look, you're working for a phenomenal healthcare organization, but I do have one piece of advice for you. You just never want to speak up and say what you really think in one of our staff meetings. A few weeks ago, someone from Lab spoke up and said what they really thought. No one has seen Frank since, right? And immediately, that new charge nurse has just had an experience. And their belief going forward about their role in staff meetings clearly is to keep your head down. So next time the charge nurse is in a staff meeting that is progressing down a road that she doesn't agree with, the behavior, of course, is to just keep her head down, don't speak up. And if that belief is broadly held throughout the culture, the result is quiet meetings, the meeting after the meeting in the hallway, and no one really challenging the way that we do things around here. That's how culture works. So the bottom 3 layers of this model, experiences, beliefs, and actions, represents culture. That's the way that people think, beliefs, and act, actions to get things done, results. The current culture isn't necessarily a bad culture. The current culture just happens to be perfectly aligned to produce both the desired and undesired results that we're delivering today. Quality outcomes, core measures, readmission rates, and so forth. Whatever the level of performance today is a mirror of the way that people are thinking and acting today within the organization. So to really understand how this model works, you have to segment it in half. You kind of have to insert a plane in between the top 2 and bottom 2 layers of this model. If I were to ask you, and if I were to open the phone lines here, and ask you, where do we tend to spend on the administrative side or the clinical side? Where do we tend to spend most of our time on this model? Top 2 layers or bottom 2 layers? There would be a chorus of you responding that we're wired, we're clinically trained to only acknowledge the top 2 layers of this model. We're concerned about results, and when we're not delivering the results we want to deliver, we go right to actions. In fact, we call it an action plan, don't we? We go implement it for 3 or 4 months, and when that hasn't moved the needle on patient experience or Press Ganey scores, we're right back to the action layer. And around we go. We adjust policy and procedure. We introduce new rounding questions. We tell people what they should do at 2 feet in the room, and then 4 feet in the room, and then 6 feet in the room. And we micromanage the bedside experience so tightly in an effort to get different results. In fact, the clinical diagnosis of this is actionitis, right? It's this propensity to not really, ironically, address root cause. And we know in a clinical environment what happens if you don't address root cause. The disease spreads. Addressing root cause is, from a cultural perspective, we never do it till we get to the bottom 2 layers of this model. Root cause is getting really clear on the beliefs that people hold and why they believe the things they do. I'll give you a really quick example of this. We were working with a large healthcare system in New England, and we had the director of their ER who was very concerned about getting next of kin information. They were running into instances where they needed contact information or permissions, medical history from patients, and they didn't have the next of kin information. And so she went on this crusade, and by the way, they're acquiring it 32% of the time. So she goes on this crusade to fix next of kin information. So she creates a new form. She has the form translated into 6 different languages. This is the Safety Net Hospital, Boston, Massachusetts at the time. So they needed language capability. So she has it translated into 6 different languages. And she has IT help her to create a really useful interface to acquire next of kin information. She trains every single nurse in the entire ER on how to acquire next of kin information. So immediately the scores jump up to the 90% of the time they're acquiring next of kin information. Within about 6 weeks, the numbers have fallen over the course of those 6 weeks down to 37%. So in total, she's gone from 32% up to 37%. If I were to ask you, where would you place her approach right now on this model, we would acknowledge that right now she's very much action-focused. So the question becomes, what is the belief that's getting in her way? So as we begun to dug into it, it became really clear that her problem was culture. Several prevailing beliefs that were undermining that particular strategy. Number 1 belief: when a patient comes into the ER, my priority is triaging. Next of kin information falls way down on the list of priorities when a patient comes into the ER. Another belief was that you've given us a form that's now redundant to other forms. We're already getting this information anyway. You're causing rework. So if the belief is broadly held, you're causing rework, can a nurse leader in an ER put pressure on that and cause that the form be adopted? And the answer to that, of course, yes. That nurse leader can put pressure and compliance measures in place for that behavior to change. But as soon as she takes pressure off of that and runs over here and manages compliance to this issue over here, we know what's going to happen with next of kin information. Everyone falls off process, and that nurse leader is going to be standing there going, I thought we fixed that. How in the world is this behavior popping up again? And again, we can acknowledge that we're not addressing root cause in that effort. So she became really clear that the problem was there was a belief in the way. So she began doing a number of things. One thing she started doing was in every single staff meeting, she started telling 2 stories. One story, she told about a student at Boston College who was crossing the street and was hit by a vehicle. She comes into the ER, and during treatment, she becomes unresponsive. She's a Jane Doe. They have no idea who she is because they don't have any contact information on her at that time. They continue to treat her. Her condition deteriorates, and she ends up passing away. They learn a very short time later, had they understood her medical history, they never would have treated her the way they treated her. They never would have given her the medications they gave her. She then tells a story of an elderly gentleman who also comes into the ER. He too becomes unresponsive during treatment. They have his daughter's information. They contact her. She explains he had a procedure 2 weeks ago. What was the procedure? She explains what the procedure was. Is he on medication? Yes. What medication? I don't know, but I took him to a pharmacy 2 days ago to pick up his prescription. They were able to then contact that pharmacy, ascertain the medications he was on, and triangulate what was happening and reverse the symptoms as a result of adjusting his treatment path, his treatment plan. In that case, they don't know, but they actually believe they saved a patient's life in that very instance. So she tells those stories in every single staff meeting. Last we were informed next of kin information in their operation, and their ED was being acquired 93% of the time. If you ask people today, what's your belief about next of kin information, their answer is it saves lives. It's ultimately about patient safety. When you get the belief right, people self-select. They look around at what needs to be done and they act. Do we ever, in a healthcare environment, complicate the action layer because we're trying to address a belief layer issue? We do it constantly. We do it all of the time. And we don't say that critically. We're wired in healthcare to see short-term immediate results, so we go right to the action layer. But in doing so, again, we run the risk of failing to acknowledge root cause. So the managerial approach then from a clinical environment or even an administrative environment is to try to get behavior adopted by telling them and retelling them, telling them, then bribing them, and then forcing them. That's the pattern. Tell them, bribe them, then force them to get the behavior to change, and it's a ton of work. It's a ton of energy going after behavior in that compliance, heavy management style, heavy management orientation to getting behavior to change. So if you take the model that we just introduced to you and you frame it as a patient experience model, we would just say that patient experiences lead to patient beliefs. Patient beliefs then lead to how patients act, and eventually we're producing whatever the measure is that we're using, HCAHPS or Press Ganey or whatever the instrument, we're producing our outcomes. The process then of getting really clear and honest about what the patient believes is important. We call this effort acknowledging belief bias. In other words, employees in your organization today and patients who walk into your facility, either, again, inpatient or outpatient, are walking in with patients, are walking in already with beliefs. And the problem with beliefs is that no one pops their head off from their pillow in the morning looking to invalidate the beliefs they already hold, right? We constantly look to validate our beliefs. The same is true inside of the operation. Your employees have beliefs about the way things work around here. And in a change management environment, you ignore those beliefs at great peril because you're not likely to get change to stick without acknowledging that that's happening. I'll give you a real quick example of this. Let's say we have a frontline nurse who the belief about this particular nurse is they're always late getting their stuff into the EMR. They're always late. And so this nurse sees the error of his or her ways, and they say, I'm gonna show up differently. I'm gonna start getting my information in on time. So they start getting their information on time, and they're perfect. 30 days, they're nailing it. Day 31 comes along, and they're late. What's everyone saying day 31? They're always late. We'll ignore a mountain worth of evidence that suggests change is here, that this individual is really changing, and we'll zero in on the one example to validate our beliefs. From a staffing perspective, the administrators are constantly hearing staffing levels, staffing levels, staffing levels. We're not delivering on HCAHPS, CGCAHPS, et cetera, because of staffing levels. Well, you could have administrators feeling like they have right-sized and rebalanced staffing levels throughout the operation. We've targeted it for 9 months, and then there's one pocket in the organization where it's not happening, and everyone goes, see, it's staffing. The reason we're not delivering is staffing. We did 45 frontline interviews with one of the busiest hospitals in the United States, happens to be connected with one of the 3 largest for-profit healthcare systems in our country. And 45 frontline interviews, rather. We did it over the course of a full day with 6 people from our hospital team conducting these interviews. One of the questions we asked is, why aren't HCAHPS moving more rapidly in the ascent, in the positive direction? And 41, when we brought our interviews back together that evening and we compared them, 41 out of 45 of the interviewees answered that question the exact same way. They said, staffing. So we put our data together. The next morning, we're introducing what we heard to the officer team. We had about a 2-hour meeting with them, and their heads like collectively explode. They cannot believe that the narrative within the organization is dedicated to staffing levels. That's belief bias. In fact, they dug in and they said, so did you interview anyone from EVS, within environmental services? And we said, yeah, we interviewed 6 people. Did they talk about staffing levels? Yeah, 5 out of 6 talked about staffing levels. We're plus 7 FTEs right now in environmental services. How are they talking about staffing? That's the narrative. And every hospital in America, every healthcare organization in America has that narrative. That's the power, again, of belief bias. So the highlights of this particular model: the results model is intended to apply to your entire staff, but also to your patients. Your patients walk in looking to validate the beliefs they hold about the kind of care they're going to get in your facility. And you can deliver 99 things perfectly and you miss on the one. You're late on discharge because the physician does his rounds or her rounds before entering the discharge orders, and you get dinged despite the fact that you had the patient experience perfect throughout their stay. It applies to patients and to your entire staff. Your staff's beliefs are driving their actions, which are producing the results you're getting now. That's kind of the punchline of this whole model. So getting to the beliefs your staff hold becomes really important. Next, strategy or action layer initiatives are not alone, they're not sufficient in and of themselves to sustain higher patient experience scores. You will wear yourself out iterating at the top two layers of the model. And then forcing staff to execute on that strategy, it becomes even more futile if they hold beliefs that are contrary to the actions being required of them, because the belief always wins. People are always going to default back to the belief they hold. So sustaining higher patient experience scores requires changing the way that people think and act to achieve these desired results. So what does that look like? One application of this model that I've just introduced to you is an application of the philosophy, is to enroll the broader organization in participating in a patient-centered culture. What does that look like? Let me take the model I just introduced to you and simplify it into a model that looks like this. E1 plus B1 plus A1 equals R1. R1 represents the results we're delivering today. E1 simply are the experiences and beliefs and actions that are currently manifesting themselves within the work environment. And we refer to that as C1, or the current culture. C1 is perfectly, beautifully, 100% aligned to deliver R1. The problem with C1 isn't that it's bad or not necessarily the right culture. The problem with C1 is that it's not aligned to deliver on something that we call R2. And R2 represents the results that we need to deliver in the next 3 to 5 years. It's the next level of quality outcomes, safety outcomes. It's the next level of patient experience and HCAHPS scores. It's readmission rates. It's wherever we're targeting. That's our R2. And by the way, most hospitals are, and this is for another webinar another day, but most hospitals are terrible at defining R2 because we're too complex. We try to define 150 things that we ask the organization to do when they can typically only remember 3 or 4. So R2 gets defined. And what typically happens is we take R2 and we put it out to the organization and we introduce a compelling business case behind it. We say, you know, our neighboring hospitals in our community are all going after the same thing we are right now with population health and elevating the patient experience, and there is a business case to do what we do better. And sometimes that case for change is compelling, and we talk about retail health, and we talk about Walmart opening outpatient clinics and the fact that we have a different playing field than we've ever seen before, and it gets people's attention. The problem is we just stop there after introducing R2 to the organization and giving them a compelling case for change, and we just drop R2 on top of C1. In other words, we just remove R1, we drop R2 on top of C1, and we wonder, why aren't we delivering R2? Why aren't we elevating these scores? And the answer, of course, is that nothing has shifted in the way that people are thinking and acting that we could expect to deliver on R2 in a way that we can replicate, in a way that we can sustain year after year after year. So there's a real cathartic, meaningful experience in our interaction and the consulting work that we're engaged in when we start engaging with expanded leadership teams around what C2 needs to look like. The amazing thing about that process is they tend to be really aligned around what aspects of the culture today are most undermining and eroding our ability to deliver on C2. So we do some listening to the organization. We interview, we assess, and we get aligned around C1 and the corresponding C2. And all of that happens through the lens of what we call R2, or the results that we need to deliver. So this becomes the framework. This becomes the philosophical core model number one relative to the philosophy. And we, of course, define C2. And we do that by by creating really pithy, memorable, directive cultural belief statements that capture the essence of the way that we need people shifting, the way we need people changing how they think and act. So if C1 is we're unbelievably complicated, resource constrained because we overdo it with initiatives. We have 80 different initiatives we throw on the organization all at one time. That's C1. C2 would be to focus and simplify. So we capture that in a meaningful way. If C1 is us versus them between nurses and physicians and administrative staff between the clinical side, C2 is one team. If C1 is we make decisions through the lens of what's most important to us versus C2 being we make decisions through the lens of what will thrill our patients, that's a cultural shift. And until it's defined, it will constantly churn. People will bump up against it all the time until we actually write a constitution that says this is how we show up. This is how we behave. And without a constitution, it tends to be a free-for-all. So culture, getting intentional about culture, balances the approach to leading our organizations so that we have guidelines, we have guide rails for how we interact. Model number 2, this is the second component, if you will, of the philosophy that we're laying out here, centers on the need to redefine personal accountability in a positive and principled way. If you go back to the results pyramid model for a moment and you consider the experiences people have and those experiences leading to beliefs, and I've just talked about that at a macro organizational level, but that model also applies to me as an individual. I create experiences for my peers. I create experiences for those who report to me and for those who I report to, and those experiences lead to beliefs. And those beliefs are either working for me, and there might be some of those beliefs that are actually working against me. The most important set of beliefs that I can be tuned into personally, we would suggest, deal with the topic of personal integrity and personal accountability. Held about me, beliefs that are held about me, people aren't making stuff up, they're rooted in experiences. So this model, the second model that we're going to introduce to you, is a model that we call the steps to accountability, and it brings context and meaning to, and even definition to what accountability is versus what it isn't. The model is deceptively simple, as is the first model that we showed to you. It's divided by something we simply call the line. The line represents engagement. Below the line, you find varying degrees of disengagement. Above the line, you find total engagement. Below the line is where people tend to be focused on all of the uncontrollables. When people are above the line, they tend to be focused on things they can control. Below the line, externalization, justification, stories as to why I can't deliver at the level you're asking me to deliver. The mind share and the energy is dedicated to the story as to why it's so difficult when the culture drifts below the line. I should say when individuals drift below the line and the culture follows. When people are above the line, there's a mindset of what else can I do? Is there anything I haven't done or we haven't done that we could do or should do to get the result? Below the line, I didn't get the results. It's really not my fault. My hands are tied. There's nothing I can do about it. That's the narrative. When people are above the line, there's a tangible connection between that individual and the outcome that they're trying to deliver and an energy to actually make that happen. Below the line, all the energy is on the story. How else do I tell the story as to why this is so difficult so that I buy myself more time and kind of get myself off the hook? And we could really have some fun with this model if we unmuted the lines here and we just went around the horn on these below the line behaviors and asked you, what does it sound like? What does below the line sound like when you're not delivering on the patient experience in your organization? And you go to ignore and deny, and there's not even, when people are ignore and deny, they're not even breathing, right? They're not even conscious. There's maybe even a denial that HCAHPS are even on our radar, right? I had no idea that was an area of focus for us. It's not my job would be another below the line story or tendency where I work to convince you that the problem is over there with the physicians. If we had employed physicians, this wouldn't be an issue. But because we're working with a physician group, we can't deliver, and the physicians really are the problem for not delivering on the patient experience. And let me send you, I don't know what your calendar looks like, but if you want to go dig into what's wrong with HCAHPS, Mr. COO, go talk to the physicians. Finger pointing, nursing shortages. We're in a bad community. It's just a tough demographic that we operate in. Confusion, tell me what to do, and confusion runs the gamut. It's the great defender of the status quo. It's actually a skill set. If you know, some people become so good at confusion that they use it every day, right? It becomes the great defender of the status quo. Cover your tail would be producing documents that would suggest our trend is better than the competition down the street, or cover your tail would be any emails that have been used to send to administrators or vice versa, suggesting that if we don't get more resources here, we're not going to be able to deliver on the patient experience. And wait and see is pretty intuitive, right? Wait and see is delay and buy myself more time. Now, as simple and intuitive as these categories are, when you just consider for a moment, how much time do we spend below the line? How much hallway conversation do we spend focused on all of the uncontrollables? And if you consider, if we were able to take all of that energy and displace it to a productive place, if we had it actually displaced on what else can we do to deliver on the patient experience, it becomes really, really powerful. If you take a straw poll of 100 managers and you ask them the question, are you accountable? Right now, if you just did that today, send out a pulse survey to 100 managers, say, are you accountable? You're going to get a 100% response rate to that question. 100% of your people are going to say, absolutely. You're not going to have one person say, you know, I'm a train wreck, right? Don't count on me for much. You're just not going to hear that. But if you ask a second question, do we need more accountability around here? You're going to have a 100% response rate on that question too. You're going to have 100% of people say, yeah, and let me tell you about it. It's labs, right? It's EVS. They're too slow. That's the problem. And so we end up in this great paradox where, asked collectively, do we need more accountability around here? The answer is a resounding yes. Yet when you ask the individual, how are you doing, you get the same answer. We're really good at externalizing accountability downwards, outwards, upwards, and out there, and not included in that consideration, of course, is me. So as cliche as it might sound, the most important person to get above the line is me, and you begin doing that by creating awareness as to what accountability is versus what it isn't, what it sounds like to be accountable versus what a lack thereof sounds like. And with that, you now have a framework to define personal accountability. We could spend another hour and a half on this particular topic and operationalizing this model, but the philosophy, you have it. It's very simple. The more people we get operating above the line, the better the results. That's the punchline. So you have now the two central philosophical models that we use in the consulting work we do around building a patient-centered culture. If I were to ask you, does the patient sense the culture of your facility? Does the patient sense if the staff is below the line? The answer, of course, is yes. So we've talked a lot about the philosophy here. We maybe took 15 to 20 minutes to do that. We're going to spend the remainder of our time giving you a high-level overview of the methodology. So if we've defined R2, and we've defined the desired state by virtue of cultural beliefs and operating above the line as kind of the philosophical framework for how we need people behaving, how do you bring that to life? How do you keep it from being a poster campaign, which people have experienced 20 times throughout their career? How do you make it a living, breathing leadership tool so that it has a material impact on the behavior of leaders and frontline staff? Methodology. So we begin in the work we do by introducing what we call culture management tools. These tools are and I'll just introduce them to you high level: focused feedback, focused recognition, focused storytelling, and focused accountability. What do they all have in common? They're focused. What are they focused on? R2 and C2. How do you start lining up the way that you recognize people so that it's connected to the desired state? How do you start intentionally telling stories in a way where stories, by the way, rest at the bottom layer of that model? They are third-party experiences that reinforce either C1 or C2 thinking. So how do you methodically and purposefully tell stories that illustrate and give life and color to the desired state? That comes to life very much as focused storytelling gets integrated into our meeting structure. Focused feedback. How do we start communicating around the contradictions? And how do we start reinforcing what it looks like when it happens right? That happens through the lens of focused feedback. And then focused accountability. How do we create meaningful, what we refer to as type 1 experiences to accelerate change? Type 1 experiences are experiences that when they happen, they immediately shift beliefs. They're that unique and insightful that they cause change to happen in the moment. So initially, we operationalize the change by introducing these culture management tools and then get really clear on how they integrate into the meeting structure of our workflow, both in one-on-ones and in staff meetings. So the overall methodology that we use keys off of the philosophical frameworks of these two models, and then the case for change. And then we introduce, again, culture management tools, cultural beliefs to the organization, this idea of having culture-changing conversations, and a final element that we call systems alignment. And the systems alignment work is integrating the desired state, whatever we define the patient experience to be, that gets integrated into our systems. How we hire, who we promote, how we recognize, performance management systems, policies and procedures that betray the cultural shift, policies and procedures that even are below the licensed of some of our highly paid professionals, but we're having them do work that pulls them away from thrilling our patients. Well, that's all work that happens in systems alignment. That brings us to really 3 words that capture the essence of the consulting work we do, and we call it train, retain, and sustain. This is also part of the methodology. So I'll spend 20 seconds on each one of these. The purpose of training is to freeze belief bias. Even on this webinar, that's what I'm kind of working on with you, is when you freeze belief bias, it causes people for a period of time to say, okay, maybe things could be different around here, and maybe I could be a part of that happening. But we don't anticipate seeing wholesale critical mass behavior change happening by virtue of training. Exposure doesn't equal mastery. Mastery comes from repeated exposure and practice over time, which brings us to retention. We tend to see behavior really start to change in our retention phase. People need to hear the same message 7 times, 7 different ways. There's a ton of science behind that before it really sticks. So how do you come back with the same message in different right-brained ways over the course of months and years so that people realize this is actually here to stay? And then the sustained piece gets back to what I was mentioning a moment ago, and that is systems alignment. You never really have tackled an effort like this until it gets into your DNA. And it's not into your DNA until it's woven into your systems, until you're evaluating policy and procedure and budget allocation and compensation and so on and so forth through the lens of C2. So C2 now becomes, and culture now becomes strategy. It becomes strategic. The process map that you're looking at here is a high-level eye chart that we give you, not to go through the granular detail here, but to give you a sense that process that's integrated over time is how you get traction. I'm on the phone Thursday of last week with the CEO of a very well-known hospital in the Atlanta, Georgia area, who has gone from the 2nd percentile on Press Ganey to, in 12 months, jumping from the 2nd percentile up to the 42nd percentile. They just ran it again, and they're just south of the 70th percentile. In 24 months, and their HCAHPS scores, so that's their engagement scores. Their HCAHPS scores, although not as dramatic, are mirroring the same trend. And we have the opportunity to write about those types of case studies month in and month out as this process gets integrated into the leadership cadence. So if you are reading the eye chart, you're seeing the amount of effort and attention given to senior leadership, because they become the tail that wags the dog in these types of change efforts. It's where the contradictions are loudest, and it's where the modeling has the greatest ripple effect down throughout the organization. So we've given you a high-level overview of a philosophical change work, or change management framework, and we've also given you an overview of the methodology. We know that we've, in many instances, sparked more questions than we've given you answers. There's a lot more that we could go into. And it's one of the reasons we want to end this webinar with an opportunity to hear from you with a Q&A. We've had some questions, some chats coming in as this webinar has progressed, and if you haven't had the opportunity to send in a chat, go ahead and do that now. I should say a question. Go ahead and do that now. We'll take the time for 4 or 5 questions as we kind of, or as many, if there are more that come in beyond that, we'll take more time than that if we have time. All right, so the first question is from Aaron. Aaron asks, as an ER nurse, it's hard to communicate what needs to get done, and as the night gets busy, we are all concerned with our own duties. How can your models enable us to work in an environment that is centered around controlled chaos? So, Aaron, there's probably not a person on this webinar who doesn't relate to what you've just described around controlled chaos. We're great in crisis mode is a mantra that we hear in a lot of our healthcare clients. And you're referencing as well the challenge that the night shift often feels that they're not part of and connected to the communication. We believe that for people to change, there has to be an experiential introduction into why they need to be changed. They need to be heard, in other words. Night shift and weekends, they often wear, and some do it with great pride, the redheaded stepchild badge because they feel like they're out of the loop on everything. We do have thoughts on the process map that deals with enrolling those groups. And again, it needs to be experiential. There has to be an experiential introduction to the change effort. What we've done here today is an overview, but it's not experiential, right? There's a way to actually be experiential with it. When you ask and you start listening to frontline staff, night shift, weekend shift describe C1, what's amazing about that is they will tend to describe it in very similar terms to what the expanded leadership team described it as, or how they described it. And as they begin to realize that their description of C1 in real time, we actually pull it out of them, and then they overlay that with the leadership team's description of C1, there's remarkable consistency in how they describe C1 because they're all experiencing it together. Administrators are hearing the feedback, but the front lines are living it constantly. They're bumping into it all the time. So it's and we could go deeper in response to your question. I've been rolling them, but the simple answer is their voice needs to be heard. It needs to be experiential, and that can't happen by sending posters out to the organization or ensuring that they get the email on the new norms or the new behaviors. It has to be much more experiential than that. The second question comes from Camilla. I'm a nursing manager, and I work alongside many doctors that are stuck in old ways of running a hospital floor. How do you enroll physicians in a change effort like this? One of the most consistent questions, Camilla, that we're asked when work like this begins is, will our physicians engage around this? Our experience is physicians come into this type of meeting kicking and screaming in some instances at worst, and at best dragging their feet. They're skeptical that it's really going to get any traction, and they don't know that they should really invest their time because they have a lot of things they could otherwise be doing. What we'll tell you is I can't think of, in my nearly 15 years of working in this space with hospitals, I can't think of a physician group, a leadership group that walked in to the initial experience we do with the expanded leadership team and didn't, after the initial 2-day experience, leave anything other than totally enrolled and engaged in what we did. So physicians are as concerned about the culture as the support side, the non-clinical side is. They just don't tend to be, they don't tend to couch it as cultural. They don't put it in a culture bucket, but they have their frustrations. And when you start to hear them articulate what they are, they don't tend to be out here in right field from what everyone else is saying on the non-clinical side. So the physician voice and enrolling physician leadership is critical. And similar to the last question from Aaron, the enrollment of physicians deeper into the organization also needs to be experiential. And by that, I don't mean a 2-day meeting. That doesn't work for physician groups, but there is a way to enroll physicians in the process as well. Again, Kamala, thanks for posing a really central issue, right? If you talk about the patient experience and you miss the physicians, you're in trouble. All right, another question from Carrie. We've tried numerous times to improve our hospital readmission scores and HCAHPS scores. We succeeded, but nothing seems to be causing enough change. After changing our process multiple times, how would your concept of culture make an immediate effect in this space? So, Carrie, a couple of things as far as immediate space. The definition around R2 and getting really tight and succinct around the results we need to deliver in the next 3 to 5 years is a very common gap, and it has immediate impact. People want to follow honesty and integrity, but they will follow clarity. They want to follow values like honesty and integrity, but the thing people will follow is clarity. And so they want that clarity. In many instances, they're working in so much complexity that they just want to see the big picture. So R2, in defining it, has immediate impact. We would tell you that defining C2 in the desired state has similar impact because you now have introduced common language for, and maybe a better way of saying it is a point of alignment as to how we show up and interface with one another. Without that, it tends to be more of a free-for-all. With it, you have, I'll go back to the parallel of having a constitution. You have something to come back to that is a point that we can agree, this is how we're going to show up and interact with one another. That's immediate impact. The other thing I would say as far as immediate impact from an ROI or a measurability standpoint is go look at your leading indicators of engagement scores. If our engagement scores start moving up, we know inherently there's a correlation with what's going to happen with the clinical scores. There's cause and effect in how people engage in the workplace and the scores that we're producing that is 100% evidence-based. And Studer's done a ton of work on that as well. Gallup has a lot of work on that. But if we can get people engaged at a higher level, good things tend to follow. So we would suggest that's not day one. It's not even week one. But immediate impact in the first 9 to 12 months on overall engagement scores, whether on the physician side or employee side, would be an example of more intermediate effect. We'll need to stop there because of time, and any additional questions that have come in, we're happy to take offline and interact with you in perhaps a more customized way for your organization. We do appreciate the questions that have been posed, and sorry we can't answer all of them here in this forum. An email will be coming your direction from us the next day or two that will give you an opportunity to go deeper with us. We'd be happy to hop on a phone call and just hear and understand better what brought you onto this webinar and how the principles and models that we've introduced to you here today could have application impact in your organization. Again, thank you for your interest. Thank you for taking the time to join us today on this webinar. We'll be in touch with you soon.
If you would like to dive deeper into the concepts presented today, our public workshops and our best-selling books are great options.